first of all, this will be recorded, so the people who can't make it can access it. So you will have to press that button to say that you're okay with it being recorded. Otherwise, jump off. It's not going to be used for any purposes other, no names and all that sort of thing. It's just to have it as more CPD for people who are quite hungry for CPD, especially around pharmacology, we find. And certainly into the future, if anyone's got anything that they want me to organise, these webinars are going very, very well, so and very well attended. So if anyone's got any ideas of what they particularly want, just email me or Ebony. Ebony is our events organizer, is doing a wonderful job. So I'll stop talking and introduce Dr. Donnellan-Fernandez. I personally have known Ros for many, many, many years, back in the old South Australia home birth days and MGP days, and now she is a senior lecturer in midwifery at the Griffith University, and she's going to be speaking on pharmacology today. So welcome, Ros, and thanks for your time.
Thanks very much, Belinda, and welcome everybody this afternoon. Hopefully you can all hear me okay. So yeah, I think it was about this time last year actually that I joined QNMU for a pharmacology update, and I'll just preface what I'm going to say today with I'm going to give you a very brief review for those who might not have been at the session last year, to emphasise the National Prescribing Competencies Framework, and then we'll get into the more recent legislative changes around the Drugs and Poisons Act and regulations that are very specific to Queensland midwives or any midwives moving into Queensland and practicing in that state. So hopefully that's okay with everyone, and that's what you've signed up for today, because I will also preface it with legislation can be a little boring, but I've tried to cover things that are very specifically relevant to the audience today. So first of all, I'd just like to acknowledge country as well, the traditional custodians of the land on which we are all meeting, which will be various across the state, and if there's anyone from interstate. And I also want to pay my respect to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples. So the update today, the focus of the presentation is around a legislation and regulation update for midwives, for all midwives, whether you are endorsed and a prescriber or whether you are a registered midwife. So firstly, as I mentioned, I gave a full presentation, and it's probably available for you as CPD this time last year, around the updated NPS, National Prescribing Service Prescribing Competencies Framework. The one before that was 2012, and 2021 they updated it, and that was multidisciplinary. A lot of work went into it, and it's a very high quality document. So I just want to bring people's attention to that, and also give you an update around where some of those resources, again for all midwives, that the previous National Prescribing Service developed will be hosted, because they've moved with our change in government and with an evolving change to our services in that area. Then we'll whiz through and focus on the part 2, which is about the 2019 Medicines and Poisons Act, specific for Queensland, and the MPMR regs that accompany that, and how they relate specifically to midwives and endorsed midwives in Queensland. So first of all, just again, the National Prescribing Competencies Framework, NPS is very much about embedding quality use of medicines. And this document, the link is current and functional. It will work for you, and bring up that document. And I'd refer all midwives to it, because whether you are a prescriber and endorsed, or you are a midwife administering, supplying or acting on the prescription orders of others, this document is relevant, because it it holds up the quality competency standards for any prescriber, basically. And as I mentioned, from the 1st of January this year, NPS MedicineWise, which also have a lot of very good education modules and other CPD around quality use of medicines, is no longer being funded by the Department of Health and Aged Care, but the Australian Commission on Safety and Quality in Healthcare now have responsibility or stewardship of a lot of the resources that were quality resources that were developed by NPS, and those resources are being hosted by the Commission going forward till we find out what else happens in that space. So that Prescribing Competencies Framework describes the competencies for all health professionals who prescribe, and its focus is around safety and quality use of medicines in the Australian healthcare system, wherever you work and whatever your context of practice. And certainly a national approach to that is important going forward as well, to have a consistent standardised approach to contemporary prescribing, to support prescribers across a broad range of disciplines, and to contribute to safety and quality in the community, and also to importantly ensure that prescribers, whichever discipline they belong to, are adequately prepared and keep up to date with changes. So the framework itself, the aim of it is there on the slide for you, and in conjunction with the National Midwife Standards for Practice, these are the standards that we use and that currently underpin the current curriculum framework for prescribing, or for the Prescribing for Midwifery course at Griffith. And the framework ensures shared understandings of prescribing, and including around the development of education and training, around professional development for multidisciplinary teams, for self-reflection, for regulation, and also for recognition of the prescribing role more broadly. The Australian definition of prescribing is up there for you, but essentially this framework focuses on safe use of medicines, person-centred use of medicines, and quality use of medicine. And the 4 stages of prescribing, which we covered in the session last year, are as depicted there for you: information gathering, clinical decision making, communication, monitoring, review, and all those things are covered very specifically under the national competencies. Now, as those now relate to the new provisions for midwives in Queensland with the advent of the 2019 Medicine and Poisons Act and the new MPMR is an acronym for the regulations which accompany that, which became effective in September 2021. And those things actually replace and supersede the former drug therapy protocol, which many people who've worked in Queensland a long time would have been familiar with. Now, the National Prescribing Framework, I just want to emphasise, Section 1 is a prescribing competencies, Section 2 is the guidelines for achieving the competencies, and there's 7 core areas for professionals that support prescribing practice. They're up there on the slide for you, and as I've said, this is just a brief review really of a more comprehensive presentation last year, but these are current and active, and a lot of work went into developing them, so they're very useful for practice and for currently endorsed midwives. Each of those 7 domains is underpinned by more specific domains, just like our national standards for midwife practice are, and I've just put an example of one up there for you to show that they are very detailed in terms of the actions and activities expected of prescribers in retaining currency and competency. And the other thing I just want to emphasise, because I know often it's difficult when people come around to do their CPD and think, oh, well, how do I actually show that? Or what area should I be focusing on? Or what time have I got to focus on this year? And there are really good real world examples and easy to understand examples in the back of that prescribing competency framework that go across each of the areas. And so you can clearly see where you might be strong or where you might want to do some more work, or perhaps you haven't looked at something in that area for a number of years and you might want to focus your CPD on that for the next 12 months going forward. So again, that's just a very brief overview of that presentation from last year. Moving now into the new legislation. First of all, you can access the instruments or the legislation word for word for anyone, and it always is good to do that, because looking at someone else's presentation or even a government summary of documents or protocols can be quite different to the actual word for word legislation itself. So the links are up there for you if you actually want to consult or have a copy of those documents specifically for yourself. And what I'm going to do today is to point you very specifically and to look at, I've screenshotted a couple of segments or the section that's specifically relevant to midwives and registered midwives and endorsed midwives from the Schedule 6 of the MPMR. Also, though, for those who eyes might glaze over and go, oh, that's really technical and complicated language, and I am having difficulty understanding it, Queensland Health actually have a very good fact sheet, 7-page fact sheet or information sheet around or a summary of what these are updates and regulations mean for midwives in Queensland. And much of the material in this presentation has come from that fact sheet, including links to other what are called legislative instruments that are relevant for midwives who practice in Queensland, whether you are employed through a government instrumentality like Queensland Health and one of the various health and hospital services, or whether you're practicing in another context, say in a private sector setting or a community organisation or in private practice, because the legislation in Queensland is actually linked to some of the other departmental standards and documents that I've also put the links in for you today. So just by way of overview, Queensland had an overhaul in 2009 of their previous legislation around the regulation of medicines in that state. And the idea was to contemporise and update the prior legislation to modernise and streamline basically the regulatory framework for management of medicines and poisons in the state, and including for practitioners in health and also other areas, because the legislation also refers to vets and animals and a range of other providers, and also to environmental poisons and use of substances that come under the gambit of this Act. So the scheme in its entirety is aimed at a better monitoring, essentially. It's a public health approach to responding to health risks associated with inappropriate access and use of regulated substances. And the Act really has made some inroads into an attempt to provide greater assurance to the community that medicines, poisons, and those other activities, including devices and things that come under the Commonwealth legislation and the Therapeutic Goods Act, are regulated by a framework that keeps the public safe, essentially. So what's the extended practice authority, and what's it mean for us? So this is a very specific legislation, is about specific use of words often, and this is the wording as used in the legislation, the EPA, or extended practice authority. And basically what it does, it gives power, or lets the Director General make authorisations or approvals for particular places or contexts where people who have the appropriate training, education and skills can undertake additional regulated activities with medicines. And it's not a free range approval or authorisation. They're quite specific. The EPA's actually imposed conditions on the person who's given the authorisations on how they actually can deal with the medicines or substances they're given approval for. And they're very specific to particular groups, classes, or persons who hold particular titles, such as nurses and midwives. So in making an EPA, the Director General gives consideration to a range of factors, and they might be things like community access or lack of access to healthcare, and also any risks that might be associated with the proposed dealing with the medicines, and also governance capability or oversight of the entity and its responsibility for oversight of the person and the framework they're working within. So that can vary, that latter context, depending on whether you're rural, remote, metro, or what sort of organisation you are employed by or are working within. And, you know, for some people that can be complicated. For example, if they're with the RFDS and doing cross-border practice, or, you know, across multiple contexts and states, or if they're an endorsed midwife and they have perhaps a part-time contract with a government health service, and then they're doing private practice in another context. So it can really change. What I want to emphasise, I guess, today is that the EPA is profession specific. So legislation is very specific, and the Extended Practice Authority, there's one for midwives and there's one for nurses. So those are protected titles under the National Health Practitioner Regulation, and those two links I've put up are the two different information sheets provided by Queensland Health, one for midwives, registered midwives, endorsed midwives, the other one for nurses, including nurse practitioners, registered nurses, enrolled nurses. And there's also some provisions in these legislations for students of nursing and students of midwifery. As well, in terms of how they need to be supervised in relation to when they're undertaking their education and handling medicines. So under the provisions of the MPMR, midwives and endorsed midwives are approved persons to undertake regulated activities with medicines. Now, if you do download the legislation, and particularly the regs, the September 2021 regs, where you go to is about page 150 something, Schedule 7, Part 2, and you'll see it's clearly identified nursing and midwifery, and that's where you get the Extended Practice Authority provisions for both those groups. As I've said, it replaces the drug therapy protocol. Some of the transition or practice, though, is very similar, as in it's been brought across in this legislation. Yeah, so again, the EPA has a very particular meaning, and whatever is authorised can be very specific. So the example there is that normally to administer a S4 medicine requires a prescription, particularly if you're not a prescriber and you have an authorisation to administer. However, the EPA can make an exception to that circumstance, and others, as we'll see. The other thing that's really important to emphasise, and I think this is relevant going forward in relation to a whole lot of professional discussions potentially and within different practice contexts about what extended practice, what the EPA enables, because the extended practice under the legislation refers to the authority and the authorisation. It is in no way defining the professional practice or scope of the approved person as extended practice. So an EPA doesn't mean you are doing extended practice. However, that is potentially how it might be proposed or interpreted for a variety of reasons by particular individuals or groups or sectors or organisations, again, for a range of different reasons. So, as I said, that Schedule 7 Part 2 sets out the types of activities, and it's very explicit, the dealings, it's called, or dealing around medicines, and your scope, if you're a midwife or if you're endorsed midwife or nurse practitioner or whatever. And it specifies, there's 3 columns. I'm going to show you those in a minute. It specifies the circumstances. Sorry, there's the medicines column, the dealings column, and then the authority column. And as I've mentioned, it also there's provisions for when students might possess and administer medicines while they're training to obtain a qualification as a midwife. So the terms are really important in legislation. These are the main ones. And if you look at that information sheet, the link earlier I put up from Queensland Health around what this means for midwives, there's an appendix at the back, and these are the main terms that the appendix looks at. Authorised way, deals, to give a treatment dose. They talk about monitored medicines, dispensing and supply. There's a range of others, but these are probably the main ones, the most important ones that mean particular things. And so authorisation is again about what's been permitted or authorised by the Director General for the health authority or for the person, which then the instrument may be being delegated or delivered through the health authority or hospital. So it describes what the person is actually able to do within the EPA. And they need to comply with those requirements as specified under the MPA and MPMR, and that's all in Schedule 7. However, as I mentioned earlier as well, in addition to the legislation and the regs, there's a range of these other departmental standards, and we'll get to some of them as well. So they talk about all sorts of other things around, disposing of medications, storage of medications, and a range of other aspects that you need to be aware of, because particularly, but not only, but particularly if you're employed within a government hospital, you'll automatically be required to know about these things. You may have to do, health education modules in relation to them, but because they are considered a legislative instrument linked to the provisions of this EPA, they're also relevant for others who might work in other practice contexts, including private practice. So deals, deals is considered to be any of the following activities: purchasing, manufacturing, possessing, supplying, selling, dispensing, or giving a treatment dose, or, as I've mentioned, disposing of waste as well. So it covers a range of different activities. Giving a dose, this is different to dispensing or making a medication available to a person. It's about actually administering the medication or supplying one or more doses to a person. And there are very specific provisions around that. Monitored medicines, which most of you are probably very familiar with, is a term used to describe a list of medicines. These are usually the DDAs and controlled substances. However, there are others in there as well. There's a list of them in the regulations, and use of these medicines is monitored via real-time prescription monitoring, or what's known as Q-script. Also really important to be aware of if you work in Queensland, there's various terms used in the legislation, which people say, what do they use all these different things? But there's a monitored medicine, there's a high-risk medicine, and there's a restricted medicine. And one example of that, so codeine often comes up, and codeine is considered a high-risk medicine. So it's not a restricted medicine, and yes, midwives who authorised prescribers may prescribe it, but there's a whole lot of other specific requirements that go with that authority or responsibility, if you like, whereas the medications that are restricted medicines and listed as such under that schedule, you cannot prescribe them even if you are an authorised prescriber. However, under some circumstances, you can apply for a specific authorisation where there may be a particular individual or a practice context where that might be very relevant to you. There's a really great information sheet as well, again, for people who are endorsed prescribers around writing lawful prescriptions, available there in the Queensland Health suite of documents. And what is good about that specifically for midwives who are prescribers in Queensland is there's some, I won't say quirky, but some very specific requirements that are different to prescribers in other states. So as we know, 8 states and territories make up sort of colonised Australia, or the federated nation of Australia, and the legislation and regulations are different across each context. So that makes it quite complicated for some persons who might move contexts or states or territories, or for those who engage in cross-border practice. Dispensing relates to a person selling a medicine to a patient on the authority of a prescriber. So usually this relates to pharmacists. And supply, midwives, registered midwives and endorsed midwives may certainly be involved in supply. It's an umbrella term that includes selling, dispensing or administering a treatment dose, but it doesn't include administering or disposing of waste. So other terms that are really important: prescription, standing order and clinical protocol. People who've been in practice a long time would recognise these are all very different things, but sometimes language and terms are used interchangeably by us in everyday conversations with people, and particularly for newer persons new to the profession or early in practice, it can be really confusing. So each of these things are quite different and mean quite different things under the legislation. So a prescription is an instruction when it's issued in a lawful way under all those requirements. The issuing a lawful prescription in Queensland are followed by a person who's authorised to issue that prescription either in writing or increasingly under an electronic framework now. So yes, that information sheet is very useful. Similar to the previous legislation, a prescriber who gives an oral prescription, for example, a telephone order for a controlled substance or monitored medicine, must confirm that prescription in writing no later than the next business day. In contrast, a standing order is a document authorising a medication to be administered or given as a treatment dose to a person, mother or baby, at a relevant institution or under particular circumstances at a particular service location or place. And an approved person who administers a medicine, which might be a registered midwife on a standing order, must make and keep a record of that administration. And there's very specific information on making standard orders that are covered under the part of the legislation mentioned there. And lastly, a clinical protocol, which many of us are very familiar with because sometimes they aren't consistent. Mind you, in Queensland, they tend to be very standardised or consistent clinical protocols, at least across government institutional settings, but that's not necessarily the case in all jurisdictions. This can be a type of standing order applying in relation to a specified class of approved persons. And there's an example provided there for you. So that's something that's very specific that directs the practice of that particular provider in relation to dealing with the medicine in a particular circumstance. So all that's probably very dry and boring, but what's it actually mean for us in clinical practice? Well, specifically, as I've said, a registered midwife is someone who's currently registered with NMBA and AHPRA under the Health Practitioner Regulation national law and authorised to practice midwifery or in the midwifery profession as a midwife. Part 2 has the table for registered midwives, and I'm going to show you that shortly. And in Division 3, speaks specifically to endorsed midwives, those who are authorised for scheduled medicines and to prescribe, and they have a separate table as well. The other thing just worth mentioning here is there's a specific definition of childbirth that precedes the midwife or that opens the midwife section, and basically that definition is around from the onset of regular contractions essentially until birth and expulsion of the placenta and membranes. And that's relevant, as we'll see, in relation to the registered midwife extended practice authority authorisations. So this, in terms of endorsed midwives now, so sorry, I'm skipping around a bit, but for people who prescribe, Section 7 enables you to prescribe orally or in writing, which includes electronic prescriptions, national inpatient medication chart prescriptions, and also administering and dispensing treatment doses of medicines, except for the restricted medicines, as I've mentioned. And there are certain authorisations you can apply for if you're in a, might be someone with a substance dependence issue, or you're in a context where you can't get ready access to particular medications that are important. But again, generally you might be in collaborative arrangements with other providers in those circumstances, unless you are very, very remote. Again, those legislative instruments, here's an example of one. If you're a prescriber and endorsed prescriber in Queensland, you must comply with the monitored medicines legislative instrument, which haven't got time to go into that today, but there's the link to the document on the screen. And what that means is that if you are prescribing a monitored medicine and you're authorised to do so, that you've got to check the monitored medicines database or Q script before prescribing or giving a treatment dose of that medication. There's some other requirements. I won't go through all of them up there, but they are on the slide, and this is specifically for midwife prescribers in Queensland, and they're an example. This list actually is taken straight from the information sheet produced by Queensland Health for endorsed midwife prescribers in Queensland. So there are specific requirements there around prescriptions for S8 medications, around high-risk medications, and also some particular requirements about what you can and can't do if you've generated an electronic prescription and then it's incorrect and you want to make a correction, as contrasted with a handwritten prescription. So again, if you think, oh, this is all very complex, there's too many requirements, again, that Writing Lawful Prescriptions, it's about a 4-page PDF. It's really great. You can download and have in your with your practice materials. It's extremely useful. Working with QScript, haven't got time to talk much about this today, but essentially at least one national consistency, real-time access to real-time electronic prescribing, particularly for dangerous drugs, controlled drugs, drugs of dependence, or monitored medicine drugs. QScript will enable the provider to, or the provider actually has, the prescriber has to engage with that system. And if you're employed by Queensland Health and fortunate enough to be in a prescribing role within the context of your employment, you're probably having to complete a QScript training as a condition of your employment. But also other people who may not be employed by Queensland Health, you can get access by using your APRA registration information to identify yourself on the database. I was going to stop for questions and concerns, but I might, sorry, what's the time? Oh no, hopefully going okay for time. Unless there's any burning ones, and then get to questions at the end. Actually, I'll just stop for a minute, have a drink. Are there any questions, or should we keep going and have a roundup at the end?
I can't see any questions in the chat. If anyone's got a question, if you want to throw it in the chat.
Yes, Bieber, honestly, no question is too small or too weird or too silly. And you know what? I've discovered some things in preparing for this presentation today that that I have to update myself in, because the deeper you look into, think, oh, right,
Yes.
that's changed as well. So, you know, learning all the time.
Yeah, I certainly feel that myself.
And I know, look, just as if for anyone who's online who's done the prescribing course, or the, you know, Western Australia, Tasmania, Victoria, and it's variable. There are quirky variations in every place, and it's really challenging keeping on top of all the changes. But again, if you've got a prescribing endorsement, you have to keep up to date, because it does change.
So we've got Nick has asked, can we get a copy of the links discussed? Well, they'll have access to this PowerPoint, Jos?
Yeah, definitely, Belinda. And the links, I will tell you as well, because I checked all this morning, they are all current and do work, because there was one actually on, I can't remember which one, but it didn't work. So I've checked them all, and they are all, as of today, actually they will link you to those Queensland Health ones, particularly to the information sheets, but also, as I've mentioned, the MPS National Prescribing Competencies Framework. Yes, all those you can still go straight, if you Google it, it'll take you straight to the document, and it looks like NPS prescriber service, but that is going to change. So we had a little anxiety attack around education materials, but they are all going to be hosted there apparently, and if they migrate to somewhere else, no doubt all health professional groups will be updated about that, because they're required for safe practice.
I did have a quick Google as you were doing it, and I found them very easily. So yeah, and then there's someone interested in the Griffith prescribers course.
Okay, not a problem. They'll probably take that one offline, because we're full for trimester 1. I'm just putting we're more than full, and their trimester 2's filling very fast. So yeah, but happy to speak to people after the presentation about that, or answer questions at the end if we've got time. Sorry, phone's binging. No, that's okay. Yeah. In relation to restricted medicine, so they're the ones, and there's a list, a very specific list of them. And as I've said, most of them are controlled substances, but not all. There's other things like pregabalin, you know, the things that interest us would be codeine and probably tramadol. Sorry, they're high risk medicines. But the restricted medicines are ones that actually prescribers can't prescribe without a specific authorisation, and you can check your prescriber column to see if it's restricted or not, or the schedule at the beginning of the MPR regs. And as I've pointed out, codeine is currently listed in Schedule 2 as a high risk medicine, not as a restricted medicine, but it is also on the monitored medicines or Q script requirements for checking before you actually issue a prescription, if you are an authorised prescriber or you administer a treatment dose. So this area relates, or this slide relates to both registered midwives. Someone's very demand. Anyway, sorry, my phone's beeping. I've just removed it. This slide relates to both registered midwives and endorsed midwives, and both are authorised to give treatment doses of medicines as detailed under the schedule, but they have to comply with the requirements specified under the MPR to ensure the activity is conducted in the authorised way. So yeah, treatment dose allows one or more doses to be given. And there's some other requirements too around giving a treatment dose. So if you're a registered midwife of any category who supplies or gives a dose of an S4, a prescription medicine, or an S8, a monitored medicine or a controlled substance, you must attach a label to the medicine and record the supply. And there's also, it's not on this slide, but it's in one coming up, a specific Queensland Health information sheet around that as well, around what the requirements for that are if you work in a practice context that, is not a hospital or institution where you've got like a DDA cupboard. So a midwife who gives a treatment dose and is filling a prescription of either S4s or S8s can supply it, even if it's less than the manufacturer's standard pack. But in order to fill the prescription, the medicine can be packaged into another containers. However, S2s and S3s have to be supplied in the manufacturer's packaging, which contain information about how to safely administer and store the medication. Now, just briefly, you can find these tables yourself if you download the MPMR on, I don't think the page number's on there, but it's alphabetically listed for all the different professional groups. And this is the section for registered midwives. So you can see there, very similar in terms of the translation of what the EPA enables to the previous DPA, if you have an extended practice authority around actually administering medications or giving a treatment dose, including a preliminary treatment dose. This is the second part of the registered midwife table, and as I mentioned before, there's a specific definition of childbirth, and this again enables the person with the EPA to deal with the medicines in this way. So really it's fairly broad scope, provided the extended practice authority is in place. And then there's some other provisions there around repackaging or giving purchase orders, and also disposing of medications, and I'll speak to that at the end. So for endorsed midwives that come under the next category after the registered midwife, this essentially, again, it's a lot smaller or shorter, because essentially the midwife who is endorsed for scheduled medicines and has the ARPA approval and the prescriber number can prescribe the S4s and S8s and deal with medicines in the way described, providing they issue the lawful prescription and they comply. I guess this is around compliance with the other legislative instruments that link to their prescribing authority, if they are practicing in Queensland, which include these other documents that are in this presentation. So some other things that are good to be aware of are expired prescriptions. Midwives and endorsed midwives can't give treatment doses or administer medicines on a prescription that's expired. How long does a prescription last? For S2s, 3s and 4s, 12 months, essentially, it's valid. If it's outside that range, it's not valid any longer. But for S8s, they're valid for 6 months. So that's important to be aware of. And expired medicines, there's particular provisions in relation to that. You can't give a treatment dose if the expiry date's on the container or label that the medication's in. This substance management plan, and there's a specific Queensland Health data sheet or information sheet for this around a particular requirements. It's relevant to people who may be working in areas where they are interacting with persons with substance management issues or addictions, and or under the legislation, there's specific provisions for places as well, and one is prisons. So pregnant women are in prisons, but also many registered nurses practice in prisons too, providing a range of services. So if you are in circumstances where you're having cause to be dealing with a lot of regulated substances, then this is a really important legislative instrument to that will be relevant to your practice, essentially. Other requirements, so the other main ones, again, these are all on the Q Health information sheet, but particularly storage of medicine, record keeping, very important, including electronic provisions around electronic record keeping, and disposal of medications. That has changed significantly. And then notification or notify requirements, things that you're obligated to notify. So around storage and record keeping, medicines obviously should be stored according to the manufacturer and product information to maintain their integrity, and also to risk manage, so people aren't unintentionally poisoned or overdosing. Relevant provisions for this section are up there on the slide. And then there again is another legislative instrument or departmental guide around what you are required to do in Queensland around secure storage of S8 medicines or monitored medicines and controlled substances, regardless of your practice context. Disposal of medicines. So this includes S8s. There are different arrangements now. So previously, I didn't know, but apparently they were sent to forensic and scientific services, and now they're different processes. Most waste can be sent to apparently an approved waste management contractor for high temperature incineration. Who might be an approved waste management contractor if you're in private practice? Well, there's a Q Health fact sheet on that as well. So there's places where you can get this information. But one of the specifics around controlled substances or monitored medicines is that whatever it's come in, it should be rendered unusable first by the person responsible or dealing with the medication before it's forwarded on for disposal. And then there's a range of reporting requirements, and there is a whole list of various reporting sheets on that link for various things. And it says at the bottom of it, if you can't find the right form here, there's one, a miscellaneous serves all. So probably that'd be the one I'd be going for. Yeah, and obviously one of the most important ones is you are now required to notify lost or stolen S8 medicines, and the implementation of the Q script provisions and the updated 2019 Poisons Act are a direct attempt to deal with this area, but there's then specific provisions, or obligations upon registered health professionals as well. I'm going to stop and let someone else speak if they'd like to. What I'm really interested to know is if anyone is using an EPA, or anyone online today, or knows anyone else who is, if you've got any experiences, good, bad, or otherwise, to share, or any issues, that you think are really hot at the moment in this space that need to be addressed, because it's certainly, from my perspective, appears to be an area of gaining some greater interest from health authorities in Queensland. So I think that's probably a good thing in terms of increasing access to services for women. So if anyone's got any brilliant ideas or stories to share, or ways to creative solutions to any issues they might have, that's always really helpful. So I'm going to stop talking and open it up.
No worries. People can raise their hands if they like. Thanks heaps for that, Ros. I was just thinking as you were going through, I feel like when I start prescribing again, I'm going to have a folder of all of these the legislation, regulations, and all of the sheets, information sheets.
Yeah, look, it's probably not a bad idea.
Okay, so I suspect for us to see everyone, to be able to see hands up, you'll have to
stop screen sharing. Okay. I'll talk to the person about the prescribing after. One thing I just wanted to say briefly before we open it up was my supplementary slides. If you have engaged with this presentation today, support and collaboration with our other providers is really important, and everyone would be aware, I'm sure, online of the updated National Midwifery Guidelines for consultation and referral. But also, the last two competencies of the National Prescribing Competency Framework, if you are an endorsed midwife prescriber, you are fulfilling them today by doing this presentation. So, you're well with, if you go and consult that document, you will see that the areas we are covering are certainly some of the very specific areas around professional prescribing that are covered in the competencies. So you can claim your CPD points without any qualms. Now, how do I stop sharing, Belinda?
I think you just go down to the green button again. Ebony, are you online, or Colleen?
Yep, just here.
There we go.
Yep, all good. I've stopped the screen sharing.
Thank you.
Thank you. So you can see in the chat column, I was unaware the mid-DTP was no longer relevant. When is it no longer effective from? I think this is a surprise to a lot of people because it took us a lot of time to socialise the DTP many moons ago.
Look, don't be embarrassed at all because, if you are making some assumptions, because these new legislative instruments were effective as of September 2021. Essentially, and look, there might have been some transition provisions, and if there were, I don't know what they are, because it's hard enough keeping on top of everything. But quite frankly, the DTP, once the new regulations, the MPMR, came into being in September 2021, effectively the DTP is no longer from a legislation point of view active. So this is a very new space, and it's thank you for that, whoever's put that there, because I have found this consistently when I came to Queensland and became involved in the prescribing course there. About 2 years into the initial few offerings, when I became involved, yes, I would speak with people who were already endorsed prescribers around other regulatory changes, and they'd say, "What do you mean it's different? No, we do it like this." I said, "Well, actually, it's changed. I've had to update, information for the course," and this is another one of those examples. So, yes, the communication and the filtering out of the knowledge doesn't always happen as well as perhaps what it could, because that information sheet, as I've said, that's 2021. It was issued by Queensland Health, and it is very good. It's 7 pages specifically for midwives, and then there's one for nurses as well, or different categories of nurses. But obviously some people haven't seen that. Possibly many people haven't seen it.
And I suspect, Ros, what people don't realise as well, Queensland Health has got a directive, a policy now for midwives with an endorsement to be able to use it within their public employment. It's just up to the HHSs to enact that. So a lot of midwives don't realise there's actually a policy that supports midwives with an endorsement being able to use it. So D has just said that they're using it at that's Townsville University Hospital. They're using the EPA. Beautiful. And can you see the chat, Ros?
No, I can't, unless, hang on, I'm just going to see if that makes a difference. I'm clicking on it. Oh, yes, I can now. Thank you.
Oh, good, because there's a question from Joe along.
Where's, how far? That's right, I'll screen. Joe to everyone. Sorry, can't video.
Yep,
is that Joe's?
Yep.
Wondering if we could have some worked examples of how changes impact our current practice. For example, maybe we used to be able to administer XYZ in this situation, but now we can't without a doctor prescribed order. That would help me relate the dry. Yeah, thanks for the question, Joe. I know it's always a bit tricky with examples because they're not necessarily applicable to everyone. But from my perspective, I mean, and I'm not a not a lawyer or a legislative interpreter, but the best I can say, many of us who worked in other states and were endorsed for midwife prescribing and worked in context in other states were very jealous of Queensland's DTP protocol for a long time, I can tell you, because trying to get traction in that area and other jurisdictions was quite challenging 10 or 15 years Oh, no, probably not yet. Anyway, at least 10 years ago. So that's moved forward, and some places are moving forward apace with generally good leadership in the space, either at a health Department of Health level or within particular, local government authorities who are driving those things forward. But from what I can tell, as best I can tell, I'll put that caveat on, from this legislation, it's not about restricting your practice any further. In fact, this is about extending access to medicines and to quality use of medicines by prescribers, by people, including midwives, who are authorised, trained and qualified to do so, under appropriate circumstances. The difficulty is for some health authorities and institutional settings is how that translates on the ground. And that's where I think all these other legislative instruments I kept referring to, that's why how they come about. So this is guidance for people who might go, oh, well, that's all very well and good, but we're out here at, whoop, whoop. And if we've got someone with a substance, dependence issue, and you're saying we can manage them out here, well, how are we going to do that and comply with, these other policies and protocols?
I would suggest, if you don't mind me saying, Ros, I would suggest that if it's been changed and now you have to get a doctor to order it, that is just a local misunderstanding of the changes. And so I would go to if you've got a midwifery consultative forum, or if you can talk to your midwifery manager and just really nut out what it is, how you're working and how it will work for you. And then you could go through to Optimo, the Office of the Chief Nursing and Midwifery Office, if it's changed to your detriment, because it shouldn't. Like Ros said, it's meant to be increasing your access and your autonomy, not decreasing it. So if that's happened, there's ways around it. You just need to find out what's going on in your space and move it forward, because Queensland is pretty far ahead with that. It was 2010 we got the DTP app rolled out. So Queensland is pretty good setup for midwives, but like Ross said, it's around the interpretation. Angie, I think you'll be the last question. We've got 3 minutes left.
I'll unmute myself. Hi, Belle. Within Metro North, we've had varying things around the DTP. We've had some hospitals where midwives have been allowed to use the DTP, and others where you're not allowed to use the DTP. At the RBH, we finally got the little training package that we were allowed to use it, only to find that it was outdated and the EPA had already been there to replace it. Since then, we have had a health management protocol written around the EPA, and we are just about to roll out some education around that. There's also some discussions within our NMCF meetings as well about the endorsed midwives being able to prescribe, and that being written into that at some point in the near future. My question is, and I just feel that this is going to happen, when we come to rolling out the education around using the EPA for midwives, like in general clinical practice, there is going to be, I feel, some pushback from midwives who don't want to use it. And is that perfectly okay, and they can still get everything prescribed? Because some of the things in the EPA, for example, like your Kanakian, we currently have a standing order, and I envisage, into the future that won't be required if midwives are using the EPA, and like your Hep B vaccine and stuff like that. Does that make sense?
Over to you, Ros.
Really, really interesting. Thank you, Angie. There's a few different things to unpick in there. I'll address the one around people's whatever that their reticence perhaps, or around their scope of practice, or resistance to change, or discomfort, perhaps. that's a more challenging one, you know. And again, from my perspective, that's about education. It's about bringing people along, you know, and obviously not coercing people to do things, but about often when people are supported appropriately and there's educational updates, whatever it is that the resistance might be, you know, it can be approached proactively that way. It's interesting you said about the when people got onto the DTP, or when there was the appetite to move it forward, then it was outdated. We find this with so many things in a fast, you know, changing world. And I think people often, whenever they get to the information, you know, just like we had the comment before about not realising the DTP was no longer, you know, current, we often revert to the default position. And look, the DTP is quite a sound document. It's just that legislatively now it's been superseded by something else that essentially transitions very similar provisions. But of course, everyone else, including health authorities, people that work in them, and the staff, and all their protocols and documentation have to catch up. And that's where often there's time lag and resistance. So Joe's question before, I was going to say to that, it would be interesting to have known her context, because if that is around a protocol, you know, needing updating, or someone in the facility, you know, needing to know that conditions have changed and okay, we need to move this forward, that's, you know, that needs to be driven from a different perspective sometimes, as contrasted where if there's deliberate blocks, you know, the myths that we all know go on, oh, you're not allowed to do that, or that's prohibited. And then someone goes, well, hang on, I've had a look at the regs and actually, look, no, it doesn't say that at all. And in fact, if we produce a protocol, you know, and then we ensure, you know, this and this is done, well, that's how to make the transition or change happen for us. Yeah, solution, you know, being solution focused, I think, to every block that might come up is an approach that I've started to try to use.
I've just put in the chat, I think just talking about this and recognising how little is known about it, how it affects the DTP, because the DTP was just awesome, I thought. But that was kind of my baby at the time. So I think I'll organise a meeting separate. And so if anyone is interested in being a part of maybe a work group, so that we can get some clear communication out to the HHSs, and we can actually put it through NAMIC, which is where all the executive directors of nursing and midwifery and the chief nurse and all those people sit with the QNMU. So I might do some work into the future around that. So if you could email me, oh no, I could probably put an email. Ebony, can I put an email out to everyone who's registered?
Absolutely. Yes, you can.
Oh, good. I'll do that. I will do that. Ros, I'll give you the last thing to say, because someone's asked a good question about vaccines.
I was just going to say, I know we're out of time, but I saw the question about vaccination, and just without going into it, Queensland, there's a whole range of other legislation as well, particularly since the pandemic, that made exceptions to other legislations, you know, around vaccination and stuff. So and I've been asked this question in a number of other forums. And again, I'm not the legislative authority, but quite frankly, a vaccine, if there is no other legislation prohibiting you from administration, is it within scope of practice? I would say, yeah, if you are educated for administration and for management of side effects of those vaccinations in the context of scope of practice for midwifery, mothers and babies, then is that authorised? Well, if there's no other instrument prohibiting it, I would say yes. You know, midwives administer rubella vaccine in the postpartum. So there's a range of very specific, you know, they're quite narrow, the number of vaccinations, but it does get down to scope of practice too. So then when we go beyond the, you know, 4 week, 6 week period, that's when the discussion becomes a lot more challenging, because and the reason for that is because often you're in the child health space where some midwives' scope of practice may not extend into that area. So it's a different discussion. Yeah, that's probably as much as I can say about that today. But in terms of a pregnant woman and a and a newborn baby to 6 weeks, yes, those things should be within scope from my perspective.
Thanks, Ros. So